Good morning, everyone. I'd like to present my PhD thesis topic, New Insights in the Treatment of Partially or Completely Edentulous Patients. I am Yasir and Mohammed, a dentist from Iraq, first-year PhD students in the Center for Translational Medicine. My supervisor is Abdulrazzaq. My vision is to provide the patient with long-term, durable, and successful prosthesis, and my mission is to investigate the recent evidences concerning implant abutments and fixed and removable prosthodontics. According to that, I have two projects. Both of them are systematic reviews and meta-analysis. The first one is comparing the long-term success of zirconia, PEK, and titanium implant abutments, started in September 2023. Second one is investigating the efficacy and safety of soft liners added to removable dentures. It started in November 2023. Regarding the first one, it is a systematic review and meta-analysis supervised by Abdulrazzaq, Petranas, SMS, Caroline's my co-investigator, and statisticians Sylvie, Naomi, and Gergely. According to the American Association of Oral and Maxillofacial Surgeons, more than 500,000 people undergoing dental implantation in the USA. So there is a compound annual growth rate of 5.7% from 2022 to 2030. Implants are made of a variety of materials. One of the components of them is the abutment, which is the connection between the fixture and the prosthesis, which can be made of a variety of materials. Titanium is the gold standard, zirconia, gold, and recently PEK, which is a synthetic polymer. Each material has advantage and disadvantage, like titanium is durable metal, ductile, but it is gray. Zirconia is aesthetic, but solid. PEK is a new material, which is smoother than titanium, and modulus of elasticity similar to that of bone. So each material has advantage and disadvantage. Our clinical question is what is the performance of zirconia, PEK, and titanium implant abutments in clinical practice. We have a PICO framework. P is the patients with implants. The intervention is zirconia or PEK abutments. Control is titanium, and the outcomes, multiple outcomes. We have like biological outcomes, bleeding on probing, survival rate, technical outcomes, color, soft tissue factors, and others. Our hypothesis is that zirconia and PEK are non-inferior to titanium regarding durability with better aesthetics. Our clinical implication is to improve the durability, functioning, and aesthetic of implant-supported prostheses. This is our, we done a systematic search in 4 databases. This is our search key. And we started from more than 11,000 articles. We ended with 34 eligible articles for full text, plus 2 after citation and references chasing. Of the finished outcomes, we have the probing depth, survival, technical, the delta E, probing depth, also bone loss for the network meta, because we have maybe network and conventional analysis. Also, we have some ongoing analysis of some outcomes like papillary index, gingival recession, plaque index, and others. First outcome I would like to present is the pocket or probing depth, which is an opening or spaces around the teeth under the gum. It is measured in millimeter with the use of periodontal probe. It may range from 1 millimeter and above, up to 3 millimeter. It is normal, but it is a progressive changes that can lead to further loosening of the implant and subsequent failure. So the lower value is the better. We divided the outcome into 3 subgroups according to the time. So we have comparison for less than 6 months, and then less than 3 years, and more than 5 years of follow-up. In the first group, the pocket depth or probing depth is compared between zirconia and titanium for a period of less than 6 months. For randomized controlled trials, compare the two. Heterogeneity is 70%. And it showed that more pocket depth in titanium compared to zirconia. So zirconia is better, and this change is statistically significant. It is more than half a millimeter mean difference. In the second period of time, which is less than 3 years, also for randomized controlled trials, compared both the treatments, and it showed that more pocket depth is present in titanium also compared to zirconia, but the mean difference is 0.14 millimeter, which is statistically non-significant. In the third group, it is more than 5 years of comparison. Also 5 randomized controlled trials compare the effect of both arms, and it showed also more pocket depth in titanium compared to zirconia, with a mean difference of 0.08 millimeter. So in summary, the pocket depth is more in titanium compared to zirconia, but in the first period of time, it is statistically significant, and we believe due to the fact that zirconia is more tissue-friendly, especially in the early stage of surgery within the period of 6 months, but later it is a non-significant difference between them. Second outcome, the survival rate, which is the ability of the implant to function properly after a period of time, and it is a summation of biological failures and technical failures. Biological failures due to the progressive bone loss and subsequent loosening of implant, and the technical failures due to loosening abutments, fracture screw, or fracture of a screw. We have the comparison between zirconia and titanium for a period of more than 5 years, 5 randomized controlled trials comparing both of them. Heterogeneity is 0%, and in both groups, 109 implants survived out of the 111. Risk ratio is relatively 1, indicating that both of them have similar survival rate for a period of more than 5 years. Third one, I will give an example of a network meta which we done between the 3 arms, PEK, titanium, and zirconia, and it is the bone loss. It is measured in a radiograph after detected clinically, and 0 is the best, but 10.2 millimeter is accepted annually. Sometimes they give the measure mesially and distally, so according to this Yoshida et al., we can divide it by 2, or we can take the maximum amount of bone loss, indicating the worst. And here is the first, the network plot, representing the 3 arms with the number of studies used to compare both of them. And the second is the consistency model, which shows that the network is consistent. The third plot is the Sukra plot, which represents 3 arms. The green is the zirconia, titanium is blue, and PEK is the red, which indicates the area under the curve. And it shows that zirconia is the best regarding bone loss for a period of 1 year. And the fourth plot is the heat or leak plot. It shows also that zirconia is the best concerning bone loss. Second one is PEK, with more bone loss in about 0.11 millimeter. And thirdly is titanium, which has more bone loss in about 0.32 millimeter, and it is statistically significant compared to zirconia. And finally, this is the rankogram, which shows that zirconia is more probably to be number 1 in the treatment, and PEK is number 2, and titanium is number 3. We have also other outcomes, but for the purpose of time. So our strength, we have all studies are randomized controlled trials. We have multiple outcomes, multiple subgroups according to the time, and there is a possibility of network and conventional meta-analysis. The limitations are there are few studies concerned with the PEK, and there are heterogeneity in the collection of data. Some collect as frequencies, others as mean and standard deviations. Also, some give average, some give regional. So that's why some outcomes could not be compared to that. For practice, zirconia showed to be the best regarding biological responses. There is no difference between zirconia and titanium regarding survival for more than 5 years, and PEK showed to be better than titanium for a period of 1 year regarding bone loss. For research, more studies should be concerned with the PEK abutments, and what is the difference between custom-made and ready-made abutments, and what is the effect of systematic health. This is our progress regarding the first project. We finished the risk of bias assessment. Regarding the second one, which is investigating the efficacy and safety of added soft liners on removable dentures, according to a survey in USA, there is more than 36 million Americans with no teeth, 90% of them having dentures, 15% of those renewing their dentures annually. This is due to frequent changes and bone resorption. So this should be relined frequently. Of the relining material are the soft liner, which has additional advantage of shock absorption and cushioning effect. So our aim is to investigate the efficacy and safety of added soft liners to removable dentures. Our clinical question is that does the addition of soft liners improve the mastication and acceptability of patients with removable dentures? PICO framework, patients with removable dentures. Intervention is dentures with liners, and control is no addition, and outcomes is the patient satisfaction, chewing ability, and the durability. our clinical implication is to improve the fitting, retention, and acceptability of patients with removable dentures. And here's my aim, is to able to submit the dentures, both of them in September, the topics in September and December subsequently. And finally, I like to finish my presentation with a quotation by Pascal Mani, said that aesthetic dentistry in itself means nothing unless associated with tooth-conserving dentistry. Thank you.
Do you have any data about failure of the technical reason of the zirconia? Because you summarized the failure like the implant failure, peri-implantitis, and abutment failure. So specifically about the technical failure.
Yeah, technical failure are divided for like fracture veneering or fracture abutment, fracture screw, fracture like that. So it measures the total technical outcomes.
Compared with the titanium?
Zirconia versus titanium, yes.
Yes, and as I saw in the final result, zirconia had better result?
I didn't show the technical, but the survival.
That's my question.
For survival rate for zirconia and titanium are relatively the same. The relative risk ratio of 1.01, but it is maybe the same.
Okay. Thank you very much.
How heterogeneous were the titanium or zirconia groups regarding the manufacturer and the surface treatment? And what do you think these two parameters would affect, let's say, the bone loss on the long run?
Thank you for your question. Well, we didn't search about these details like custom-made or ready-made or surface treatment, but I think it's only like titanium or zirconium abutments. And I think it has no that influence, because the surface treatment are mostly done to the implant rather than the abutments.
Maybe it's early to ask, but do you have any plans when you would like to make this patient satisfaction questionnaire after they during the reline, like a few weeks or few months, or what's your plan?
Well, according to the studies, there is variations between them. Some like after 6 months, after 3 months, but it is on a visual analog scale, and the patient is giving a response. So there is some heterogeneity between studies, and that's why this is causing some delay.